Good evening, everyone. Today, we have a combined session between the FRCS mentor group and Orthopedic Research UK, as usual on Wednesday evenings. We are going to start by the introduction, and today we have a very interesting session presented by Ms. Jo Dartnell, who is a consultant pediatric orthopedic surgeon in Maidstone and Tunbridge Wells NHS Trust, and Mr. Anish Sangrajka, a consultant pediatric orthopedic surgeon in North Norwich University Hospitals and NHS Trust, which they are going to give you how to play your PEDS right in the FRCS exam. We thought that coming up with the April exam, this will be very interesting. They're going to show you how to answer the pediatric vivas and how to score in this table. Please feel free to write any questions you have in the chat box, and we are going to answer them. There is MCQ after this session, and there is Viva practice in which Ms. Dartnell and Mr. Sangrajka will Viva candidates. Please message Hannah if you want to partake in the Viva practice. At the end, I would like to recommend the concise orthopedic notes, which helped me to prepare for my exam, as well as the basic science books from the OR UK. Without further ado, I would like to stop sharing, and please, Ms. Dartnell, if you want to start sharing and start vibing each other. Thank you very much.
Hi, everyone. Thanks, Joe, for that. So we're going to do something slightly a little bit different to, I expect, your other talks. And I'm going to pretend to be the examiner, and Anish is going to be the FRCS candidate. And we thought we would just go through the main core topics that you're bound to get in PEDS, and hopefully show you the exact things, well, what we would expect you as examiners to come up with. So, Anish.
Guys, while I'm answering the questions, I want you to think about what you're going to be saying in that same time. Adnan, we are going to be doing Vivas for everyone else after this. So I just see on the chat you've put you'd like to participate. You'll get your chance, mate. So yeah, while we're doing this, you need to be thinking about what you're going to be saying. And what we're going to do is you're going to get 5 minutes for your Vivas. I'm going to try and answer everything in 2.5 minutes for each thing to show it's possible, hopefully.
Brilliant. So this is a 14-year-old young man. He's had 6 months of right thigh pain. The last 48 hours has suddenly become a lot worse. And take me through your thought process. What are you thinking when looking at this? What's going on?
So we've got an AP pelvis and a frog lateral radiograph. And the obvious abnormality here is a slipped femoral epiphysis. Looking at the pictures we have, I'd be worried that this is a severe slip. I'd want to measure the Southwick angle, but it can be very tricky here. You can see on the frog lateral, you're not getting a very good frog at all. So I think it'd be safe to say that the slip angle is going to be over 50 degrees here. You've told me that things got much worse in the last 24 hours. Did you say that the symptoms were going on for a few weeks before that?
Yes, the whole thing's about 6 months altogether, but it's 48 hours now that it's much worse.
So this sounds like an acute on chronic slip. Where are we seeing him? Did he walk into the hospital?
He got wheelchaired in to A&E, down in A&E at the moment.
So what I'd really like to see is if he can stand, even with people holding him up. Is he able to stand upright?
No, he's in a lot of pain now. He can't.
Right. So this is a severe, unstable, acute on chronic slip femoral epiphysis. And it's a controversial area. There are different ways of managing this. Personally, I'd be looking at the two options of pinning in situ, but my concern would be it'd be a technically very difficult procedure to try and pin that. So the other option would be discussing it with the pediatric orthopedic surgeons to see whether they think some sort of neck shortening intracapsular osteotomy might be a better option at this stage. The controversies about this would include the timing. Some people would want to rest the patient on traction for a couple of weeks to make the acute slip chronic, whereas others say there's no difference and you can get on with your first available list. And the other kind of controversy would be the approach. Some people, I think in this country, it's very common to use the anterior approach and do something like a cuneiform or a fish osteotomy, but there is a big trend moving towards the done osteotomy through a surgical dislocation.
Okay, good. Would you like to mention anything about his other side?
So looking at Klein's line, looking at the physis, I don't see any problems there right now. I would ask him whether there have been any issues.
No, he's had no pain on that side.
No. And the other things I'd want to discuss, you did say is he 14 years old?
14, yeah.
So in terms of age, I don't think that's a big risk factor for a slip on the other side. The reported literature is about 20 to 30% for bilateral slips. I would want to know a bit about his past medical history. So does he have any issues with renal failure? Does he have any endocrinopathies?
Okay, no, he's not. He's a large lad, and no other medical problems at all.
And
okay,
do the family seem like they'd be compliant?
They're from quite a low socioeconomic group. They have DNA'd appointments about his weight and dietitian in the past.
Right.
So a bit touch and go, probably.
Okay. So yeah, that's something we'd have to take into consideration with counselling for the family.
Yeah. Would you consider prophylactic pinning of the other side, do you think?
Definitely, based on what you've said.
Yeah. Do you know any evidence around?
Well, so there's, again, some people have argued that the numbers needed to treat is quite high. So you'd be pinning a lot of hips just to save a few. There was a paper, I believe, from Dundee that showed in the British Journal of Bone and Joint Surgery that we should be pinning most of these.
Okay. Good.
And in terms of the posterior sloping angle, people do measure that. I think there's a bit of an issue with its reliability, but between 11 and 14 degrees, if there was an increase in the posterior sloping angle on the left side, that's another reason to consider pinning.
Yeah, okay. All right. How many minutes have we got?
I think we're 4 minutes now.
Okay. All right, so we've got about a minute left. You talked about the anterior approach. Would you briefly like to tell me about the anterior approach to the hip?
Yeah, the anterior approach to the hip is the modified Smith-Peterson approach for me. I'd use a bikini incision. I'd be separating sartorius from tensor fascia lata. In this case, I would split the iliac apophysis. I'd identify the rectus femoris tendon, divide it at both its heads, push rectus down, and then I'm onto the capsule. So I'd be watching out for the lateral cutaneous nerve of the thigh in the more superficial plane. But after that, you've got the branch of this femoral artery, the circumflex, but nothing else that you're really going to injure. Okay.
Why do a lot of us choose the anterior approach rather than doing a surgical hip dislocation? What's the big advantage, do you think?
I think one of the things is really that we're using the anterior approach so often. I think the surgical dislocation, the evidence for that is still very controversial. So most units that have reported their evidence or their results outside of burn have had high rates of avascular necrosis, whereas the Bernese group have said it's 0.
Yeah. Okay. Brilliant. So I think that covers the skiffies. And so everyone can see, well, Anish went straight to the diagnosis. I mean, it is obvious. You're not going to see much more of a more obvious diagnosis x-rays than that. So it's important you tell the diagnosis, to show that you know it, show, he mentioned the Southwick angle, that he knew what it was and that it was a severe one. Then going through the fact that it is controversial, and that is one of the most important things I think that we wanted to get across, that this is a massively controversial subject. And you cannot say anything too wrong in this as long as you back it up. A lot of people would pin that in situ and then deal with the consequences, and that is not wrong. in the same way that if you have worked somewhere and happy going through done osteotomies, that is not wrong, but you need to be able to back it up. Mentioned about AVN rates and started talking about the literature when we had gone through everything and gone through the risk factors. So you've got all the main points, and you can see Anish answered that in 4 minutes.
And so guys, what we'd want you to take from this is slip femoral epiphysis. You're going to talk about the slip angle. You're going to talk about stability and chronicity, and then your treatment options, which are pinning in situ, a corrective osteotomy, which could be intra or extracapsular. And really, once you talk about those things with the risk factors, that's you easily passed. So hopefully that's slips covered. That really is as much as you need to know in a Viva setting.
Yeah.
Any questions on that one? Luke's put here, is it reasonable to suggest open reduction if closed reduction not possible? Luke.
Yeah.
Luke. You might notice that I didn't mention closed reduction, okay? There's this whole thing, people say, oh, if there's a serendipitous reduction when I put them on a traction table, don't do it, okay? No. You are not going to, in the exam, just don't say, you are going to say, I will not attempt a closed reduction. In real life, some people argue that if it's a genuine acute slip with no chronic element to it, you could try a reduction in the first 24 hours. I think that's controversial. What do you think, Joe?
Yeah, do not mention that in the exam. In reality, I've had it once, and I was planning doing surgical dislocation, and it just popped back in, and my registrar says that click that he felt will live with him for the rest of his life. But actually, it was brilliant. It clicked back exactly perfectly right, but that was just luck. Do not try and reduce it, and certainly don't say it in the exam. That's opening up a big can of worms.
And so we've got, am I allowed to say names though? They're putting them there. AJ, should I mention loader classification or name it? Yeah, okay. If you read Loader's paper, he was talking about closed reductions on these hips, which is quite them. It's a really good paper. It's revolutionized practice and understanding, but there were weaknesses in it, but you should definitely mention it. But what I'm hoping is as soon as I said stable and unstable, it became clear. One of the things to clarify is you might have heard me say, can he stand upright with even 2 people holding on to him? That is a stable slip. Okay, if they can stand upright, weight bearing on their good leg, then it's a stable slip. There's this whole thing about they should be able to walk with crutches. It's not. If you've got a fractured neck of femur that is completely displaced, no one can hold you upright. Okay, so that's what an unstable slip is. Natasha, when pinning in situ with 1 screw, when do you take screw out and evidence? A lot of us, Joe, I don't know what you do. We don't take the screw out unless it's causing any issues, leave it alone. But the hip guys, I love the hip arthroplasty surgeon who said to me, leave them in, we can take them out if we have to do a THR.
Yeah.
Darren Ebrio, Parsh. Parsh has kind of fallen out of favor, okay? So this is the whole concept of the finger of God. So if you get in there within that 24 hours, you open up the capsule, release the blood, and then use a finger just to push on that femoral neck to reduce it. It is only within the first 24 hours for an acute slip, not an acute on chronic.
And they're really rare, really rare. And again, don't be getting into that in your exam.
No. So you can see we kind of just stayed in one zone. Even things like how many threads you're going to put across the epiphysis. I always find that a bit pointless because you're trying to aim at 90 degrees to the epiphysis, and then you get in as many as you safely can. If that's 3, that's 3. If it's 5, that's great.
Yeah.
And so Luke, thank you for mentioning the closed reduction because it's something we wouldn't have mentioned otherwise. So cheers. Jennifer, I've previously been advised that a stable slip includes being able to mobilize non-weight bearing with crutches. No, this is what we were saying actually, Jennifer. So it was really interesting at BISCOS, our Children's Orthopedic Society in 2019. They actually did a kind of vote on that. And people felt that that's what a stable slip was. It's not. If you can stand with people holding you up, that is a stable slip. You don't have to walk. Okay, you don't need crutches.
Think about your old grannies when you're on your trauma, on your on-call. They're not going anywhere with their fractured NOFs, are they? This is exactly the same if it's an acute unstable and it's wobbling around all over the place. It's painful. They don't want to move.
Right, and then we've got a couple of other questions coming in. Mohammed Askar, do we need to know about the new devices such as the sliding screws? just mentioning that, okay, Mohammed, if you throw that in, that is absolutely fine. What you do need to know is what size screw you're going to be using. So for a lot of us, I would use a 6.5 fully threaded. Joe, would you go same or big?
Yep, same.
Because we hear people say 4.5 and things, too small. But if you're going to throw in telescopic screws, that's fine. But then you might be asked about the evidence, and there is none. And yeah, you use them in younger children. Lambros Athanatos, I hope I'm saying these right.
Oh, hi, Lambros.
All right. He's asking if a delayed presentation, is it better to operate ASAP or wait a couple of weeks? And that's controversial. So you'll have heard that I said that at the beginning. The Swiss say even if it's acute, unstable, they will operate whenever they can. So that could be the next day. The Stanmore, so Mr. Cattrall's kind of rationale was turn that acute into a chronic. And that's what a lot of us have been doing in this country. But there's no evidence for either. But what I can tell you is that when you look at the results for the more acute surgery from everywhere else except Switzerland, the results haven't been as good. Thank you, Jennifer.
I think the thought is you're trying to get the information down by leaving it a bit, but actually when you talk to the guys involved, a lot of it was just due to the fact they couldn't get any surgical theatre time, and the kids ended up just sitting on the ward on traction until they could get in there. And like Anish says, there's no definite proper evidence behind it.
And that's the thing, okay? So guys, when you're doing your paediatric Viva, we can tell if you've done a paediatric job because you'll talk with much less certainty. If you've been reading Miller and you've been reading Banaskovich, you'll talk with such certainty, everyone will know straight away that you've not done any peds. And what you're going to hear a lot of today is, and that's controversial. Right, so Radhakrishnan, really good question. When you pin in situ, and when getting the threads in the epiphysis, will it not make the head rotate? It doesn't, because most of these have a chronic element. And that's the problem. When you open up these hips and you're looking at this epiphysis, it is stuck. Trying to actually move it is hard. So no, it doesn't rotate around as you'd think. Peter Riddleston, do we need to know the details of the osteotomies if you're going for a gold medal? Okay. Otherwise, that's why what you'll have heard I said, and this is what I'd say to my trainees, is just go with, you could go intracapsular or pin in situ, then do an extracapsular. Okay, the principle is neck shortening, because in that chronic situation, you want to shorten the neck so you take off the tension of the blood supply at the back so that you reduce the risk of AVN. Shinil Koshi, management in chronic slip with mild exacerbations, pinning with osteotomy. So again, people for mild and moderates have done pinning in situ and then done some sort of osteoplasty. For the FRCS, I wouldn't go down that. Okay, I think it'd be safest to say mild and moderate slips, just pin in situ, full stop. Would you agree, Joe?
Yeah, definitely. And you're getting advice from your tertiary paediatric centre for anything moderate or severe, aren't you? And as long as you said that, remember the FRCS is for day one consultant being safe. You are not going to be doing these. Just mention it and say, the principles behind it. These are blah, blah, blah.
And then last question, I think we better move on after this. Yeah. Mckenna, you said, after how long do you remove the screw after in situ pinning? As we were saying, we don't, unless it's causing a problem. And it's a real pain to find these screws and remove them.
The only one we've seen tried to get out was in one of my hip surgery colleagues, and he took it out of a 21-year-old. He wanted to go in the army and be a bomb disposal expert. It took him 9 hours to get this screw out.
Seriously?
So just don't bother. You don't need to.
Okay, having said that, last question, Kuram Rashid. If chondrolysis happens, what can be done? This is not FRCS level, okay? But so how can you avoid chondrolysis? Theoretically, by not perforating the femoral head. But it's surprising, I might regret saying this, but it's not that common.
No, AVN is more common. Yeah. That is your big worry, the skiffy, not chondrolysis.
And that's the situation in which you probably would have to move the screw.
Yeah. But in which case, they're probably going for a hip replacement anyway. Okay, let's go for the next one. Okay, so this is a 14-month-old little girl who's been brought into your clinic, and GP's just worried about the way she's walking. How would you approach this?
So I would start obviously by taking a full history and examination with this 14-month-old girl. I'd want to talk to the parents, ask whether this is their first child. I would want to know whether there were any problems during the pregnancy itself. Was this a normal delivery? Was she in a breech position? Is there any family history of DDH? And how has she been over those 14 months? Has she been developing normally? I'd expect all the answers to those questions to be yes. I would ask if she was breech, and if she was, did she have hip screening? And the reason why I'd ask all these questions is you can see, looking at the X-ray, that she's got a dislocated left hip. This looks congenital to me. The ossific nucleus is smaller on the left than the right. You've got an increased acetabular index on that left side, suggesting acetabular dysplasia. And this is in the fourth quadrant of Tonnes.
Okay, good. As you said, she's got a left dislocated hip and she's 14 months. What are you going to do about it? What are you going to tell mum that your plan is?
So at 14 months, there are a couple of approaches that people adopt. One would be to get in there at this stage. Personally, that's what I would do. The other approach would be to wait until 18 months and perform an open reduction with a Salter osteotomy. That's what Salter described. At this stage, I would like to talk to them about the importance of putting the hip back. I'd explain that if we leave as is, she will start walking, and she has been walking, but she's likely to develop problems as she gets older with her back and maybe even her hip becoming arthritic if she develops a pseudoacetabulum. I'd like to perform an EUA and arthrogram with a view to trying to perform a closed reduction in the first instance. If this was successful, I personally would perform an adductor and psoas tenotomy and put her in a hip spiker. I am aware that there was the biggest series of this has been from Stanmore. So Sally Tennant and Deborah Eastwood published this. And actually, when they are in this quadrant, the results aren't so good. There is a higher rate of AVN. If the closed reduction was unsuccessful, then I'd be looking at doing an open reduction instead. Okay.
And you've talked to me before about your approach to doing an open reduction, the anterior approach. You said a Salter osteotomy. What other osteotomies do you know that can be used, or is that your one of choice?
That would be my one of choice. I am aware that some people perform a femoral osteotomy. So it does depend. You can judge this by performing a test of stability as described by Tony Cattrall. But sometimes it's the femur where you might want to put in a bit of varus and do a derotation to correct the femoral anteversion, or you address the acetabulum. And what you're doing is making up that deficient anterior coverage. So that could be with a Salter osteotomy. The other ones I'm aware of are the Pemberton osteotomy and also the Degar, as actually described by Degar and not the modifications. But that can, if you put your wedges more anteriorly than posteriorly, can provide anterior coverage.
Yeah, okay. What about your treatment after that? You do the operation and that's all you need to do?
Yeah, well, so I would normally put them in a hip spiker, so a 1.5 spiker down to the ankle on the left, to the knee on the right, and then perform some form of axial imaging to check my reduction. Usually we find CT is just easier to obtain than MRI scan. And if that looks okay, then I'd normally bring the patient back at 6 weeks for a change of spiker and an EUA arthrogram.
Okay. All right. I think, should we go on to doing questions and stuff from that? Because I think everyone can see how you can answer DDH questions like that so easily. Anish obviously knows what he's talking about, but he'd gone through everything, exactly how to treat a delayed mispresentation of a DDH.
It'd be really embarrassing if I was getting it wrong. I mean, if I miss things, you will point it out, won't you, Joe? Yeah.
I can't see the questions, so
yeah. Nothing's come through. Guys, questions, DDH, this is your chance, fire away. Right, what are the degrees of flexion? This is Mckenna again. Oh no, sorry, hang on, I've missed one. Qazi Masood, would you still do an acetabular osteotomy after a closed reduction? How do you decide acetabular versus femoral?
Okay.
My personal feeling for the FRCS is, you know, just like you're going to say you'd always do an Exeter hip replacement, just say you always do a Salter osteotomy. I think that might be the safest thing, so that you don't get into this, do I do the femur, do I do the pelvis? After the age of 2, you should say, I'm aware that I might need to do a femoral shortening as well as an acetabular osteotomy. In terms of how we do decide, there is that test of stability. So what Mr. Cattrall described was, once you've done your open reduction, if all it needs is abduction and a bit of internal rotation, you do the femur, And if you need flexion, then you do a pelvic osteotomy, something like a Salter. Mckenna, what are the degrees of flexion, ER and abduction of that hip while putting for DDH? So remember, is it really you're using II and just checking which position it's best in, but it will be internal rotation, not external rotation. Okay, so your femoral head's pointing anteriorly, you're trying to keep it in. Any evidence on maintaining reduction with wires? There is a paper from Columbia, I think it was, where they talked about pinning the femoral head to the acetabulum. I think you will raise eyebrows and possibly fail your pediatric station if you mention that.
The only time I've ever put wires in is in revision ones. They are very unusual ones and certainly don't go up the neck into the acetabulum. I actually coincidentally did put a wire in one a couple of days ago, but we put it from the iliac crest into the gross trochanter in a particularly difficult DDH one. It's very unusual. Do not go into that. Do not do it.
Then Abdullah, you've asked immediate closed or open reduction or wait until 18 months. That's one of the controversies. Okay, so I think what would you do, Joe? So I would not wait, but by the time they actually get to the operating theatre with a bit of an elective waiting list, there'll be 18 months, given that they're 14 months. But what would you do if they were 12 months? Would you go in? Or would
yeah, see, my protocol is very slightly different to yours. We go in and do an open reduction at the age of 12 months. I wouldn't do a pelvic osteotomy until the age of, past 18 months, closer to 2. Yeah. But actually, a lot of the evidence shows that pelvic remodeling goes on. We don't know exactly how long, and there's lots of controversy about that, maybe up to the age of 4. And what you see on the bony side of it isn't actually what is often there. You're putting dye into the hip. They've got a lot of cartilaginous cover. So you don't often need to do a pelvic osteotomy. I am much more likely to do a femoral osteotomy, in which case I would do that at the age of 12 months. So like Anish said before, there is so much controversy about all this pediatric stuff, but as long as you say what you would do or what you have seen being done, that is fine.
And I think that's the thing. So yeah, I would do the same actually at 12 months. If I fail a closed reduction earlier, I do an open reduction and nothing else. You normally, because the earlier you put the hip back, the more remodeling potential you've got in my mind. But you could say anything really. The only problem with a pelvic osteotomy before the age of 18 months is the pelvis is so thin. It's just hard taking your graft and trying to get it stay there. But some people do it. Shanil Koshi, after closed reduction and EUA spica, would you do axial scanning immediately? Yes. Personally, it depends on how confident I am. But yeah, I think just say yes. Okay. Yeah. Would you please explain?
You can go to a CT scanner from recovery on the way back to the ward.
Mohammed Asker, would you please explain what we need to know about arthrogram for the exam? I think you need a better talk through the approach you'd use. So I'd use a medial approach, putting my needle underneath the adductor tendons, squirting some joint arthrogram dye into the joint. And for DDH, you're looking for those blocks to reduction. Okay, so you're looking for the inverted labrum, you're looking for that rose thorn sign, you're looking for the hourglass constriction. Is there an age limit for attempting closed reduction? Not really. I think most of us think that after age 18 months and beyond, it's getting less likely.
Yeah, we've certainly had a couple over the age of 2, but it is rarer. Yeah.
And some people, I think in Southampton, the guys were saying they've stopped doing closed reductions. They just do open reductions.
Yeah.
Akash, what's the advantage of performing an arthrogram before and after hip spike reduction? You need to do the arthrogram for a closed reduction, just so you can be sure that the femoral head is actually in, because you can't see it's cartilaginous. And even with an open reduction, often once we repaired the capsule, I like to squirt some dye back in just to really check, because it's really hard. You get a small view of this acetabulum. It's not like a surgical dislocation where you might have the whole thing exposed. So that's why I think an arthrogram helps.
Do we actually put an epidural catheter in?
Oh, right.
And so we can squirt a little bit of dye in when we've got the spiker on, if we're particularly worried about it.
Oh, cool. See, there you go. I'm learning as well. Do we need to talk about examination of child in viva? That was no man. You could. I kind of skipped that, but you could say I'd expect there to be a shortened leg with restricted abduction and flexion. Someone's put, please tell us more about arthrogram. We've done that. Ajay, is Degar for CP post-super deficiency? So that's what everyone says. But if you read Degar's paper, and actually it was Joe's colleague, Marcus, who put me onto this, because he's a big fan of the Degar.
Yeah.
And the big advantage of the Degar is you don't have to put wires or anything, and it's a stable osteotomy. And essentially you are breaking in the same line as a Salter, but you choose where you go through the medial cortex. But guys, this is getting way too advanced for
Don't need to
the
know.
FRCS. Comment on difference between closed reduction under sedation in the ward. You don't do it.
You don't do it.
Yeah.
It doesn't exist.
So Mckenna, you've obviously seen this somewhere where they're using ultrasound. I don't think that would be common practice, and I would stay away from talking about that. Jennifer, if given the case of a, say, 10-month-old with DDH, could you argue for immediate attempt at closed reduction, if not comfortable with medial approach, or just wait until 12 months and do anterior? I think that's down to the individual surgeon. I would definitely go for closed reduction in that first instance. And if that fails, then look at an anterior open. I always advise people to stay away from the medial approach in the Viva. It's one less thing for you to learn. And you just say there's a very high rate of AVN. Even as long as you follow up the kid, you'll find there's some AVN. And so it's preferred not to do it. Joe, do you ever do the medial open approach?
Very, very rarely. I'm much happier doing the anterior approach. You can get much better visualization of the acetabulum. It's just what we're more all used to. And like you say, AVN rates, why not just wait a couple of months and do it with a lower risk of AVN? I think the only thing we haven't talked about is Pavlik harnesses. You have to know what a Pavlik harness is, what the different straps do to get the flexion, to get the abduction. The fact you are not going to use it over the age of 6 months. And you need to know, if you're shown an ultrasound of a hip, roughly what you're looking at. I would not expect you to be able to go exactly through what an ultrasound, all the tiny little bits of ultrasound. I would expect you to know graph. I would expect you to know the varying degrees of it. But
She's
not really how to do it. Sorry?
I say you're harsh. And then Panagiotis, you've said if the closed open reduction is not successful, then what? Then you try again. Okay, if closed doesn't work, you are going to open. If you've done an open reduction and the hip is not stable, that's when you're considering your osteotomies. Remember, the osteotomies aren't just to correct bony anatomy, it's to make the hip stable. But it does happen, and then we have to go back to theatre with another plan. And I think it's happened to all of us. Which dye do you use? Omnipaque? Yes. Someone's put here approach for open reduction. We talked about the anterior approach. It's the anterior approach, but remember to talk about splitting the iliac apophysis. A lot of people who haven't done or seen an open approach forget to talk about the iliac apophysis. For infection, you don't need to split it. You do for DDH surgery. Al has asked why I prefer a medial approach for arthrogram. Do you use a medial approach as well, Joe?
Yeah, always go under the adductor tendon, aim up for ipsilateral scapula. It's just a lot easier in babies.
Yeah, I think when you're trying to, there's a small space for that anterior femoral neck, and if you're trying to bounce it, it's cartilage, so it doesn't work so well, whereas the medial approach, there's just nothing in the way. Would you still put a Pavlik in a dislocated hip?
I would put it on and then ultrasound it the following week to see whether it's back in, and you do your ortolani and barlows, try and get it in. Obviously, if it's a kind of a teratogenic one that is not going anywhere, no. But I would give it 2 weeks of trying to go in and to centralize.
Andrew Hughes, why must you wait until 18 months to perform the anterior approach? It's not the anterior approach, actually, it's the Salter. And that's why you need to wait until 18 months. Mehdi has put, from what age will you consider closed reduction? That's a really good question, actually. So Graf never put a Graf 4, he says, in a Pavlik harness. He takes them for a closed reduction. For me, so you'll see Mr. Cattrall is a big influence in my life because he used to visit us at the North Norwich. And he said, wait till 5 or 6 months, and that's what we do. Especially because you're doing tenotomies. It's amazing how easy it is to get lost in the medial part of a baby's thigh. Would you normally wait until 5 or 6 months, Joe?
Yeah, we wait till 6 months.
Yeah.
Closed reduction after 6 months.
And
it's safer anaesthetically as well. The anaesthetists are much happier to gas on that age.
Yeah. James Houston, why do you need to split the iliac apophysis? So you will all tell me that you're going to go in the plane between gluteus medius and rectus femoris, which is the superior gluteal nerve and the femoral nerve. But that's the way you separate the two, okay? Your abductors are attached to that outer table of the ileum. So when you split the apophysis and you go subperiosteal, you take everything off and it all can then peel off the capsule. Mckenna, comment on
all the way around the capsule. You've got to be able to get all the way laterally and medially. And you'll see when you're draining a septic hip, you cannot get that visualization of that capsule without splitting the apophysis. Yeah. So you have to do that.
Then Mckenna has asked on the management of territologic dislocated hip. The things to say there, Pavlik harnesses, I still give it a go, but it's less successful. Same with closed reduction, still give it a go, but it's going to be less successful. So you're looking more likely at open surgery with or without osteotomies. But it does depend on the cause, okay? So some people would say something like Spina Bifida, that's a controversial one. Some people say don't put them back, especially if it's bilateral. And others say you should try. So I think that one you've got to just say that these are the uncertainties. Rather Christian, and if you see a child at 6 months, the hip is still dislocated, would you do an EUA and arthrogram and reduce the hip and put him in a spica? Yes. Yeah. Later you find it's dislocated at 6 weeks follow-up. Would you wait till 12 months to do an open reduction or do it straight away at 8 months? I would wait.
I would wait too.
Yeah.
Mainly the risk of AVN. If you're going back in on there, you're going to increase your risk of AVN by messing it around. You might as well just go back in and do it properly. And it might have matured a bit and you get a better closed reduction even when you do it at 12 months.
And whatever you do, if you're asked in the Viva, if they say, look, you did a closed reduction, post-op CT shows it's out, what are you going to do? I would not say, I'm going to try another closed reduction. Okay, you have to say, well, I'm assuming that I did everything well the first time, so why would it work a second time? I'm listing them for an open reduction. In terms of...
You're not going to be asked this in the FRCS. If you're getting onto this sort of thing, they've run out of things to ask you and you've got 8.
Yeah. Do I consent for closed and open at the same time? Depends on the case, but yeah, maybe. How do you assess femoral anteversion during surgery? You're looking at the hip stability, but it's really difficult. Okay, so when you're trying to work out how much to derotate, everyone has their own system, putting wires in the femur and stuff. It's all a little bit voodoo. And then 2 last questions, okay, because we've really covered this.
Next one.
Is there an option of other bracing failed Pavlik harness or straight away consider closed reduction? Very good question from Pratik. Some people do try rigid bracing. Some people would go straight to closed reduction. Rami, do you start treatment early in life for graft type 2 or do you repeat ultrasound at 6 weeks? I would repeat ultrasound at 6 weeks, but what do you do, Joe, if you see a graft to age 3
2A or 2B, yeah, I would repeat it. If they're at 12 weeks and they are not getting any better, then I would think about putting them in a Pavlik harness. It's very controversial and we're actually starting, hopefully, an RCT, which hopefully will be nationwide to get some questions about that. But you will not be asked that in your FRCS.
Right, guys, no more questions, please. Otherwise, you won't get to hear about anything else. If I just answer the last 3. Right. How long for the Pavlik harness? Again, controversial. I would say until the hip looks completely normal and then just stop. In an exam, say you're going to scan it every 2 weeks and when it's normal, you discontinue. CT scan after closed and open reductions. At 2 months follow-up in Pavlik harness, the hip is dislocated. So rather Christian, if it was dislocated at 2 weeks, you shouldn't carry on, okay? No. You would put your graft 4 in a Pavlik, and if at 2 weeks it's not reducing, might not be normal, but if it's not centering, you will discontinue the Pavlik harness, okay? Protocol of immobilization after closed open reduction is a hip spica. And why is the left side common to dislocate? People think it's because of the left hip being rubbed up against mum's sacrum. Really, no one knows. Right, we're going to end the questions there for DDH, otherwise we won't be able to talk about the other things.
Okay. Here you go. So this is, you're on the neonatal unit and mum didn't attend any for her antenatal appointments at all and baby has popped out looking like this. Paediatricians are completely happy and feel that this is an isolated problem. What do you think?
Right, so this is a clinical photograph of a baby's legs. The most striking abnormality here is bilateral clubfoot, so congenital talipes equina varus. I'm a bit concerned looking at these limbs, looking at the size of the feet in relation to both tibia and both thighs. They're just it doesn't look right. There seems to be hypoplasia of the muscles at the thighs. And I'd be wondering whether this is whether there's a syndromic cause behind this rather than an idiopathic clubfoot.
Okay. What Mum's asking about what treatment you can give for the club feet. Are her feet always going to look like this?
No, I'd explain that actually that most club feet, especially if they're idiopathic, are successfully treated by the Ponseti method, which is a sequence of plaster changes. We'll be doing that. We can start that as soon as baby is well enough. So if there are no other problems with this baby, we could do that within the next week or so. And it's a series of plaster casts, and we perform a correction in a specific sequence. So you're looking at we're supinating the first ray first, then you're going to correct the varus, and the last thing you then bring up is correcting the equinus. I'd explain that 90% of babies will need an Achilles tenotomy, which we'd usually perform in clinic under local anesthetic. Usually it's 6 weeks of plaster casting, providing everything's coming along okay. And then they'd go into the final plaster for 3 weeks, and then boots and bars, which will be full time, and then nights and naps only until the age of 5. And with this, there's about a 90% success rate. Okay.
Why did you get club feet? Do you know any reasons why they think?
It's something that we don't really know. We know that there are various theories about this. What we do know is that the whole leg from below the knee is abnormal. Studies have shown that certain muscle compartments, so the lateral compartment and the anterior compartment, are underdeveloped. About 50% of these children are also missing their dorsalis pedis pulse. So we know there are genetic factors. It's more common in boys, and this condition demonstrates the Carter effect. And we know that it does run in families, but it's the Carter effect that it explains why it skips generations. We know that there's an increase in myofibroblasts when you look at this tissue histologically, but really we don't know why it occurs. It's not a packaging disorder.
Okay. Are there any other associations? Anything else you'd be worried about? You said you'd worry about syndromes. Anything else you would routinely look at?
So one of the controversial associations is DDH. There are various papers published by Robin Payton that suggest that there isn't a genuine association between clubfoot and DDH, but I believe most people and most units do still scan children born with clubfoot for DDH. With these children, I would do a full head-to-toe examination. I'd also be looking for external signs of spinal deformity and dysraphism to exclude conditions like Spina Bifida. And yeah, here I'm just still wondering whether these are featureless limbs. I'm not seeing lots of creases. And every time I see a bilateral congenital talipes equinovarus, I'd be thinking about arthrogryposis.
Yeah. Good. Okay, any questions that have come through?
Yeah, there are a few.
Okay.
So, Kurum, I thought this pic of arthrogryposis, that's what I was wondering. I didn't want to jump in with it because I wasn't completely sure. Is it arthrogryposis, Joe?
Yeah, I think it is arthrogryposis.
Yeah. Thomas, what is the Carter effect? Basically, the Carter effect, it's a genetic thing where a certain amount, so you have a certain amount of genetic load, and you need differing amounts of genetic load to manifest the phenotype. So in clubfoot, the theory is females can have the same amount of genetic load, but not demonstrate the condition, whereas a male will have that and demonstrate the condition. So it explains why you can have conditions that are more common in one gender than the other, but without having a relationship to the sex chromosomes. Keith, ideal answer, if asked about management of bilateral club feet presenting late in a teenager, you are not going to get that. Okay. And that's really controversial. Let's not go there. Everyone knows the answer is frames, but we won't talk about that. Yeah. Kurum, why yes, caves clubfoot happens in spinal dysraphism. Do you know, mate, the honest answer of all of these things, none of us know, but it's to do with muscle imbalances. And why is Ponseti cast extended above the knee? It's to provide that rotational stability. It's really important. People have mucked around with all of those things and found it doesn't work. You've got to do it above the knee.
Cool. Is that all of them?
Yeah. Oh, yeah. A couple more. Okay. Do we need to know the genetic associations? Not really. Just say it runs in families. For the less astute of us, what are the hints in this photo that this is arthrogryposis? It's a tricky one, and that's why I was a little bit unsure, but those legs just don't look normal. Normally they'd have very chubby thighs. What we talk about is the lack of skin creases and the featureless. If you look at these, they just look tubular and shiny. And I think that's what would make you think it's arthrogryposis.
And bilateral, very severe club feet as well, should always ring
Yeah.
out. Something you haven't talked about is the Pirani score.
Yeah, someone's just put that.
Away out of 6, you get 3 points for the 3 posterior elements. So the empty heel, posterior crease, and the rigid equinus, and then 3 points for the medial or the midfoot. So the medial crease, the uncovered tailor head, and the medial lateral curve border. And so that's a way of looking at these club feet right from the start to the finish, and the physios grade them at each time just to make sure that everything is going well. And it's not until you've got rid of all of the 3 midfoot things that you can consider doing your Achilles tenotomy. So I wouldn't expect you to know much about the Pirani score, but I'd expect you to know that it exists, and it's a way of kind of monitoring the progress of these club feet.
Mckenna has put PITX in terms of the gene. So yeah, if you know it, throw it in. Ajay has asked about scoring. Joe's just answered that. No man, what is the age and indication of doing posterior medial release? There are very few indications, okay? Ponseti is the main one. I think the only indication would be failed Ponseti multiple times. So it's the syndromic feet.
We just don't do posterior medial releases anymore. They're not done. And the only one seen is in one that was a really abnormal foot with multiple tarsal coalitions. And I think it's just not.
And so normally they're about 18 months by the time you tried the Ponseti a few times and then gone in to do that. Tib-ant transfer, so depending on what you read, someone's put a Tib-ant transfer question mark. Yes, 25 to 30%. Shinil, Joe's answered your question about Pirani. So you don't need to know it in detail, but just be able to name it. Kuram, if clubfoot is part of arthrogryposis, would you treat with Ponseti? Yeah, there are papers on using Ponseti for syndromic club feet. You do give it a go. There are various tips and tricks that the Ponseti purists know about. I'm not one of them. And the main thing, if someone asks you, is that you're going to probably be using more plaster casts. That's the main thing.
Recurrence rates are much higher.
Thomas has put, speaking of arthrogryposis, how in depth should we know about it? I wouldn't go into masses of detail, okay, but you need to know that there's the distal type, there's the complex type, and just that it can cause territologic hip dislocations, it can cause knee extension deformities and clubfoot. Management of residual deformity at older age, Tamara has asked. I think there are various osteotomies, fusions. The Tib-ant transfer is the main one I think they'll ask you about, okay, and that would be it. Rami, what if casting failed or late presentation? Any role for gradual correction of external fixation? Depends on who you speak to. I think definitely so. Yeah. Joe says so as well.
Yeah, and our team, several of our colleagues have gone out to Africa, and they are very, very pro doing Ponseti casting almost at any age, and they have seen it work late teens, early 20s. So it's a quick, easy thing to do, whereas putting frames on is horrible. And yeah, it's worth doing Ponseti first, I would.
Yeah. Mckenna's put, please explain what exactly is a rocker bottom deformity. So that's where you're basically trying to correct that equinus, but rather than correcting the equinus, you're doing it through the midfoot. And that's not a good thing to do. Should we mention doing x-rays? Jahan has said. So actually, if you're being really good with your evidence and saying, actually, I know that John Herzenberg in Baltimore uses x-rays to assess whether Achilles tenotomy is required, then yes, but not just for measuring feet, not just for diagnosis. Mckenna's asked about the exact difference between residual, recurrent, and resistant CTV. And apparently you've forgotten 2 more R's. Do you know anything about this 5 R's, Joe?
5 R's? No.
No. So I'm just guessing here, Mckenna. Residual means there's still a little bit of deformity when you finished. Recurrent means you got it better and then it's come back. And resistant means you never got it better to begin with because it was probably syndromic. I've never heard of that. So you'll have to teach us about that one. Pratik, how to diagnose dynamic supination clinically? when you watch them walk, they kind of lift that first ray like that. That's all it is. And if you get them dorsiflex, they'll kind of do that. So that's just literally supination. Man, Mckenna, I don't know what you've been reading, but you've got more knowledge than I have. Do we need to know PAVER score, PAVER in capitals?
Never heard of it.
For the older CTV. I'm going to take that as a no. Martina, would allow weight bearing if using Ponseti in an older child. Good question. I think it can be hard to control that. You go with above knee plasters, they probably won't walk, they'll crawl around, and I think you've got to accept that that's what's going to happen.
Yeah. I think the only thing we haven't covered that I would like to say is the boots and butt. The highest rate of recurrence is non-compliance. So right from the start, you need to tell the parents they need to keep this kid in boots and bars, nights and nap times. And if they don't, their feet will recur. Okay.
Right, it's 8:20. So should we do one more and then throw it open to everyone else?
Yeah. Okay, it says 7-year-old boy. He's actually the son of one of our local GPs. Wants to play for West Ham, like his 2 twin sisters, and he's been complaining of severe left hip pain for the last few months. He's clinically very well, got no other medical problems.
So this is an AP pelvis, and it shows that this 7-year-old boy has perforated hip. Shenton's line is intact, but you can see that if you look at the lateral pillar, there's over 50% loss of height. So this is a herring C. There are some head at risk signs. I can see metaphyseal cyst. I do wonder if there's some lateral epiphyseal calcification. And so I'd want to know a little bit more about this child in terms of working out what I'd be in terms of my management.
Okay, he comes in sitting in a wheelchair. He's very reluctant to weight bear on this at all. He holds the hip in about 10 degrees of adduction and does not like you moving it at all. He used to comply with physio, but not anymore.
Right. It's unusual to have that degree of hip pain in this kind of condition with Perthes, so I'd be a bit concerned about this. Is he systemically well?
Yes, completely, yeah.
Right. And so it sounds like this is clinically also a head at risk. So he's got progressive loss of range of movement. It sounds like he's got an adduction contracture. And so Perthes is really controversial. People really don't know what the ideal treatment would be. Given his gender and his age, he should have a good outcome, even if we do nothing. But based on the X-ray and especially the clinical picture that you described, I'd be more likely to consider operative intervention. I'm aware that there is very little evidence that this would improve the outcome, but especially if he's struggling this much, I think this is the kind of child I'd consider admitting for traction and maybe going further with that. But it depends on how we can control his symptoms and getting complying with physiotherapy.
Okay. Do you know anything about the etiology of Perthes disease?
There have been various theories. The biggest associations we have are with passive smoking and lower socioeconomic class. Professor Dan Perry from Alderhay has published a lot of work on Perthes, and one of his most recent studies in the Bone and Joint Journal showed that there is definitely a link with being from a lower socioeconomic class, but they couldn't separate the effect of that from the effect of passive smoking. I'm aware that there's also been the BOSS study, which has just reported its preliminary results, but this was a longitudinal study surveying. It was basically a survey or a registry of all kids with Perthes disease over a 2-year period.
Okay. Good. Any questions come up? No. So what is in Perthes the ultimate treatment goal? What do you aim to do with it?
My treatment goal would be containment. That's the main principle. We need to keep the femoral head within the acetabulum. Usually this would be with physiotherapy. I ask them to stretch the adductor muscles so that they've got good abduction and keeping that femoral head moving into the acetabulum. If that's not working, there are various other approaches that have been described. Some people have described tenotomies of the adductor tendon and then broomstick plasters or A-frame braces. Others have talked about various osteotomies of the femur. Benjamin Joseph has written up a big series on those from Manipal. Others have talked about using a Salter osteotomy or a shelf. And some people put all of these things together. There is no evidence that any one of these is better than any others.
What are you going to tell the parents about this? They want them going back to football, and they want the quick fix. What's the quickest way of doing that?
I'd have to explain to them that there is no quick fix in this situation. Perthes disease lasts about 3 years. You've got the various stages. You've got the initial stage where you've got sclerosis, then fragmentation, then healing, and then the remodeling phase. Altogether, that will take about 3 years. The pain and stiffness normally lasts for about 1.5 years, and it's very variable. Even if we do an operation, that's not going to make this, well, the evidence there is controversial. Most people don't think it accelerates healing. There is some evidence from Benjamin Joseph's study group and from Sheffield Children's Hospital, where they use hip distractors, that it can accelerate healing. But as far as this family is concerned, I would not be making any promises. I'd also be warning them that because you've got total physeal involvement here, I'd be worried about proximal femoral morphology abnormality as this child gets older, and that they might need further surgery at that stage as well.
How about the other side?
Yeah, I'd like to see a frog lateral, because sometimes it's easier to see changes on a frog lateral view. Again, it's about a 25 to 30% chance of having bilateral involvement. So we'll be watching for that side as we go along with time too.
Do you know any evidence about vitamin D use in Perthes?
Do you know, I believe there is some there, but it's controversial. So there has been a paper, I think from India, that suggested that there is an association, but there's also been one that suggested there isn't.
Okay, good. Any questions come through yet?
There are, hold on a second. We have got, do you know, right, so guys, I have to say, my first thing I always say to the trainees, when you answer the question about management, is say containment. And I'm a bit disappointed that Joe had to ask me, what's the principle? So sorry about that. Right, where are we going? I'm trying to find where we were. Rami, any role for bisphosphonates in Perthes disease? Again, not FRCS level. People were investigating it, but the biggest problem is if you've got no blood supply to the femoral head and you inject intravenous medicines, it won't get to the femoral head. So people were talking about injecting it directly into the femoral head, but I don't think that got approval.
Yeah.
Alistair, how long?
If you've got, if you're using bisphosphonates in OI, you stop using them around the type of any fractures. You've got Perthes, you've got loads of little micro fractures around the place. It just doesn't, it's not a good idea, and there's no evidence for it.
How long would you traction for? So Alistair, I have to be honest, I've never come across someone with such severe Perthes, and I don't know if Joe, if that's what you're looking for with the traction, but I know that people out there do it, and essentially it'd be until the symptoms subside. So sometimes a week or two. Some people use traction a lot.
Yeah,
I try not to.
Yeah, it's not something I used, but I think it's along the same principle, like you said, of the distraction X fixes.
Yeah.
Just to let it settle down.
No, Mckenna, etiology theories, the vascular theory. There are loads of theories, okay, but none of them have been proven. So we know that there's a vascular insult. You can induce this in pigs by basically tying off the blood supply to the femoral head. But what causes that is the big issue. What I do love is when you look at the pathology, you get more cartilage forming because cartilage withstands that ischemic environment. But then that's why you get coxa magna, because the cartilage needs to be bigger because it doesn't withstand the shear forces. So that stuff makes sense to me, but I don't think anyone's actually explained why it happens. What Herring grade would this be? C. Remember, you applied the Herring grade at stage of maximal fragmentation, but it's not going to get any worse than this, is it? Chinil, how to practically distinguish between BC and C in an X-ray. The BC was something that was kind of added later. And when you read those Herring papers, there's no clarification about what that is. So my advice would be ignore that for the exam. Lauren, so if you have a child under the age of 6 with a Herring C, how would you manage this?
I don't find Herring particularly useful, I must say, and I think a lot of us completely ignore it. How I would treat a child with Perthes depends on whether they have whole head involvement, whether they have a load of head at risk signs. That lateral extrusion, that is always a really bad sign because it means that when that head is starting to remodel, they're going to impinge, they're going to have an awful shaped head. So Herring, yes, mention it, know about it, but say from experience, you know that pediatric orthopedic surgeons are more worried if the whole head has become avascular, and you just need to get containment of that. So yeah, we know that kids, no matter how old they are, if they have only a little bit that has sort of become avascular, they are generally going to do well. But if they have the whole of it that is avascular, they need some help. And you need to get that head in the right place, even if they're really young.
Yeah, I think that's the thing is that the problem with the Herring classification is that thing about applying it at peak fragmentation, by which stage you actually missed the boat for doing your surgical containment procedure. Agni Statter, worth mentioning any classification other than Herring? You could mention the Cattrall classification, but I personally don't think you need to go into that for FRCS.
The reliability of Cattrall is awful, because the only person that can reliably rescore all the Cattrall hips is Cattrall himself. No one else uses it, pretty much.
Joe.
I'm sorry. I know.
If the decision is to manage Perthes conservatively, how long do you follow the patients up, and how often do you image them? Good questions. Also, what is your threshold finding to convert conservative management to surgery? I think we have to be clear, Herbert, there is no evidence that surgery changes anything. The BOSS study has, in its preliminary results, suggested that, but it's only a 2-year follow-up. But having said all that, sometimes you just bite the bullet because you're watching and thinking, man, if I don't do anything and this ends up bad, it's my fault. And I think it's a combination of clinical factors as well as the x-ray. So I'm a big believer in the clinical head at risk signs and the radiographic. So if I'm seeing what Joe described, a progressively stiffening hip, my worry is that actually this is a hip that is slowly subluxing. And if we leave it where it is, when it does reform, it's not going to match the acetabulum. So that's what I'm looking for. So when I follow these children, I see them every 3 months with an x-ray and a definite clinical examination. And if we find that they're complying with physio and still stiffening up, in my world, that's when they're going to be looking at possible surgery.
Yeah, kids that are losing their abduction are ones that I worry about. I have quite a low threshold for taking to theatre doing an EUA arthrogram, because the anaesthetic takes away their pain. You can see their true range of movement, and putting dye into the hip I find very useful. I know that's a very paediatric orthopod thing to do. We love arthrogramming joints, but it's because you can just see it gives you so much information.
Yeah, no, definitely. Herring B, above the age of 8, would you operate? So Abdullah, again, good question. A lot of people at that age are worried. And I think if you're seeing progressive sign of femoral head collapse, again, based on those head at risk signs, the older child, I would have a lower threshold to operate.
Yeah, I'd do an EUA arthrogram, but consent them for an osteotomy at the same time.
Kurum has said, well, I thought as differential diagnosis on first look like telltale sign of septic arthritis. So Kurum, I wasn't sure. Okay, I didn't think this, to me, this isn't classic septic arthritis, but based on what Joe was describing, leukemia can also have a similar appearance. I've seen a case of that one of my colleagues dealt with, and that's why I was just a little bit paranoid. And this is an example of exam mode. When you're in exam mode, you're looking for the weird and wonderful. So even if it's really straightforward Perthes, based on the history, I was thinking, is she trying to catch me out? Is she trying to catch me out? There's over 100 people watching. Is she going to make me look like a fool? And in exam mode, you're always looking for that rare thing. Chanel, how practical is it to maintain non-weight bearing for such long periods? You might, so we didn't talk about that. I don't keep them non-weight bearing, okay? And if you do your ground reaction force diagrams, the joint reaction forces are lower with touch weight bearing than non-weight bearing. All I ask my Perthes kids to do is not run around. So yeah. I do let them walk. I don't give them
trampolines and jumping on beds.
Yeah.
I give them usually either crutches or frame or some kind of protection, and ask them not to go on long walks. That's the thing as well. And at school as well, they're generally not doing PE and running around in playtime.
Can we use Herring grading for any stage other than fragmentation? Well, it's for acute Perthes. Remember, after that, you're using the Stulberg classification. But what we were saying is it should be applied at peak fragmentation. But you only know that you've hit peak fragmentation when the next X-ray shows that you are healing up. Okay. Yeah. At what stage would you start the treatment? So Radhakrishnan, it should be before peak fragmentation. And that's why the Herring classification isn't brilliant. Shez, how would you differentiate between ABN and Perthes on an X-ray? I think some of that's going to be your history, really, because Perthes is AVN, right? So if there's a history of DDH that's been treated, and there is an association with DDH and then a late Perthes, okay, so DDH, no signs of AVN, and then suddenly age 5 or 6, there's signs of Perthes disease, and people aren't sure if the two are related. Orf has said, how would traction or spanning X-fix help? Essentially, the idea is you're reducing those joint reaction forces. You're taking the force off that soft femoral head. Hytham has put, do you do EUA and arthrogram before considering open reduction? We're not talking about open reduction in Perthes, okay? So Perthes is containment. So you're either doing a femoral osteotomy to dip it in, or you're doing a shelf, or you're doing a Salter, or you're doing both, but we're not opening up the hip joint itself. Ali, how would you treat hinged abduction? If you get hinge abduction, you've missed the boat. That's when you've got that femoral head deformity and they need a valgus osteotomy as a salvage procedure, or is what I'd say.
Yeah.
Andrew Hughes, what joint preservation techniques should trainees be able to talk about, discuss in the FRCS? None. Okay, that is all experimental stuff. Well, it's not experimental, but people are doing femoral head reduction osteotomies, okay? They're literally taking that big coxa magna, taking a wedge of the femoral head out and putting the femoral head back together. I don't know, Joe, is anyone doing that in the UK?
Andreas Roposh's.
Is it right?
He's done it a couple of times. I think Fabian's done it a couple of times as well.
Wow.
But that's certainly nothing you want to be getting into in your FRCS.
Yeah.
I mean, you saw how quickly time went when Anish was answering the questions. Know the basics behind it, know the important things that you have got to say. Don't focus on them like weird and wonderful like that. You don't need to.
And I think because I've got a message here from Imogen, who's kindly organizing the whole thing. She's saying, get a move on.
Sorry.
So last question, okay. How to differentiate Perthes from MED and SED? It's to do with that difference in time. So if you're looking at things that are happening synchronously, it's more likely to be MED. Get an X-ray of the knees or a skeletal survey if you're really worried to pick up.
Perthes doesn't happen. You don't have it in the same stage bilaterally.
Yeah. Right. So now you've seen how I approached it. You're going to show me how I should have done it by answering the Viva questions that we're going to ask you. So Joe, have you got Joe Gowder?
We're supposed to have done MCQ.
Imogen's asked us to skip the MCQs this time.
Yeah, thank you very much both for this brilliant presentation actually, and how to answer the Viva. How is the body language, how confident, of course, confidence is there. And basically that's so much important. And top tips, you know, the buzzwords, short answers, down to the point, no waffling, and controversial. Okay, you can't actually, you know what is there in the examiner's head to know what is the appropriate answer. So thank you very much.